Welcome, everyone, to a truly exhaustive deep dive into the entirety of OBGYN. We're aiming to cover, well, pretty much every nook and cranny, specifically thinking about this as your ultimate final exam revision.
That's right. It's a huge landscape.
It really is. Today, we're doing a really comprehensive exploration, drawing everything from the complete OBGYN final exam dossier. The goal is to make sure you, the learner, grasp every core concept and, all those crucial details.
Think of it like your turbocharged study session, but still incredibly thorough.
Exactly. Highlighting the essentials, connecting the dots across all the topics, our mission.
Well, our mission is to basically distill all this massive material down into something manageable, memorable insights to really boost your understanding and hopefully your confidence for the exam.
Absolutely. We want this to be the complete picture, everything you need.
Right. We'll cover the whole spectrum: labor and delivery, normal and abnormal, antenatal care, screening, benign gynec conditions, contraception, super important, gyne-oncology, those tricky pregnancy complications.
Infertility, postpartum, fetal development, even the surgical side and anatomy and menstrual cycle stuff too.
The whole works. Consider it your one-stop, comprehensive review.
Okay, let's unpack this massive field then, starting right in the beginning. Labor and delivery. For a smooth vaginal birth, the ideal setup is the baby in that well-flexed occipito-anterior position. OA, right?
That's the goal, yeah. Head down, facing the mom's back, chin tucked. Now, the denominator, that's the specific bit of the baby we use as a reference point.
Okay, so for that ideal OA position, it's the occiput, the back of the head.
Exactly. If it's a face presentation, it flips to the mentum, the chin.
And breech.
That's the sacrum. And if the baby's lying sideways, transverse, then the shoulder becomes the denominator.
We also need to mention brow presentation.
Right. For brow, the denominator is technically the occipitomental diameter. And as you said, breech is the sacrum, transverse is the shoulder. It's all about which part leads the way.
And it's not just about the presenting part, but also the baby's attitude, right? Like how flexed or extended the head is.
Precisely. Fetal attitude. Normally, we want flexion chin tucked right down. That presents the smallest head diameter.
Makes sense.
But if the head is extended, like in a face presentation, that's abnormal and makes things, well, trickier.
Then there's the position itself, left occipito anterior, LOA, for example.
Yeah.
What does that actually tell us?
It's a 3-letter code. First letter is the presenting part, occiput, on the mother's left or right. Second letter, the presenting part itself, occiput. Third letter, is it towards the mother's anterior or posterior?
So LOA means occiput is on the mother's left, towards the front.
Exactly. You divide the pelvis into quadrants: left anterior, left posterior, right posterior. Helps pinpoint the baby's orientation.
Okay, so what factors might lead to these less ideal presentations, like breech?
Good question. Prematurity is a big one. Smaller baby, more room to move around.
Right.
Also, multiple gestation, twins or more. Placenta previa, where the placenta is low down.
Uterine shape issues,
Yeah.
like bicornuate.
Yes. Uterine anomalies like septate or bicornuate uterus. Polyhydramnios, too much fluid. And certain fetal conditions like hydrocephalus or anencephaly or other structural problems.
Interesting. The dossier notes some things that aren't specifically listed as factors for breech in some contexts, like conjoined twins or a septate uterus sometimes. Specifics matter, huh?
They really do. For face presentation, factors include things like anencephaly again, a contracted maternal pelvis that hinders flexion, maybe the cord wrapped around the neck, a cystic hygroma or hydrocephaly.
And transverse lie.
Again, prematurity, placenta previa, hydramnios, uterine anomalies. But interestingly, abruptio placenta premature separation is noted as not a predisposing factor for transverse lie specifically.
And we should mention occipito posterior position, baby facing forward. That often means a longer labor, doesn't it?
It certainly can, yeah. More back pain for the mother often, too. And just to clarify terms, sitting in a squat usually describes a complete breech.
Meaning hips and knees are both flexed.
Exactly. Feet near the buttocks. That's complete breech.
Okay, let's talk stages of labor and normal progress. Active phase for a first-time mom. Say 6 centimeters to 9 centimeters. How quickly should that happen typically?
Generally, for a prima gravida, active labor starts around 4 centimeters, and a reasonable rate of dilation is about 1.2 to 1.5 centimeters per hour. So 6 to 9 centimeters in roughly 2 hours would fit within that normal range.
And before that, there's the latent phase.
Right. That's from the onset of regular contractions until you hit that faster dilation, usually around 3 to 4 centimeters. So if someone's having contractions every 5 minutes but is only 2 centimeters dilated, she's likely still in the latent phase.
Gotcha. Then second stage.
That's from full dilation, 10 centimeters until the baby's actually delivered. Its duration can vary a lot.
Depends on parity, epidural, baby's position.
Exactly. All those factors play a role.
And the third stage is delivering the placenta. Key point here. Don't just yank on the cord immediately, right?
Yep, absolutely not. Immediate cord pulling is contraindicated. Can cause uterine inversion or cord avulsion. Need to wait for signs of placental separation.
Okay, some key events during the actual delivery process. Engagement.
Engagement is when the widest diameter of the baby's head, the biparietal diameter, passes through the pelvic inlet. Clinically, we say it's engaged when the presenting part reaches the eustachian, which is level with the ischial spines.
And the head actually delivers by extension.
Yes, the primary mechanism is extension. The head pivots under the pubic bone, extending the neck so the face and forehead emerge.
Then the head turns. Restitution.
Correct. Once the head is out, it naturally rotates to realign with the shoulders, which are still inside. That's restitution.
And you mentioned parity affects duration. First babies generally take longer.
Yes. Typically the first stage, both latent and active phases, and often the second stage too, are longer for nulliparous women compared to multiparous women.
But the dilation rate in active labor might be faster for subsequent babies.
Usually, yes. Maximal dilation rate tends to be quicker in multips. Even the third stage duration can vary slightly.
Okay, let's switch to inducing labor. When would that be indicated?
Several reasons. Post-term pregnancy going significantly past the due date, preeclampsia or other hypertensive disorders, premature rupture of membranes, PROM.
IUGR. Baby not growing well?
Yes. Intrauterine growth restriction, maternal diabetes, either pre-existing or gestational, fetal demise, sadly, or chorioamnionitis, that infection of the membranes.
But you wouldn't induce if there are contraindications, like...
Right. Absolute contraindications include things like placenta previa covering the cervix, cord presentation where the cord is coming out first, a prior classical C-section scar on the uterus, or active genital herpes lesions at the time of labor.
How do we predict if induction is likely to work? The Bishop score.
Exactly. The Bishop score helps assess cervical readiness. It looks at 5 things: dilation in centimeter, effacement, thinning as a percentage, station of the head relative to the ischial spines.
Consistency, is it firm or soft?
Right. Consistency and cervical position posterior, mid, or anterior.
What's not in the Bishop score?
It doesn't directly include the baby's specific position, like OA or OP, or the overall size of the mother's pelvis.
Can you give an example of a low score, like an unfavorable cervix?
Sure. A cervix that's posterior, firm, only 50% effaced, 2 centimeter dilated, and the head is still high up at Nagum 2 station, that would get a score of 3, which is quite low, suggesting induction might be less likely to succeed easily.
And just to recap those induction contraindications again: active herpes, previa, cord presentation.
Transverse or oblique lie. Those are key ones to remember.
What happens if labor just doesn't progress? Obstructed labor.
Yes, that can happen. Causes include CPD, cephalopelvic disproportion, where the baby just doesn't fit through the pelvis, malpresentation, like a brow or shoulder presentation,
A very large baby.
microsomia, yes, or sometimes a pelvic mass, like a low-lying fibroid or an ovarian tumor blocking the way. Even a really full bladder can contribute.
What's generally not considered a cause of obstruction?
Things like a cystosol or rectosol, those vaginal wall prolapses. An ectopic kidney usually isn't in the way. And uterine fibroids, unless they're specifically located low down and physically blocking the cervix or lower segment.
A really scary situation is shoulder dystocia. Heads out, shoulders stuck. What's the immediate management?
Key maneuvers are McRoberts hyperflexing the mother's legs up onto her abdomen and applying suprapubic pressure just above the pubic bone.
And definitely not fundal pressure, right? Pushing on the top of the uterus.
Absolutely not. Fundal pressure is contraindicated. It can actually impact the shoulder further and increase the risk of injury.
And the most common complication for the baby?
Sadly, it's brachial plexus injury, often Erb's palsy, affecting the C5, C6 nerve roots.
Which nerves are usually not involved in Erb's palsy?
Typically, C7, C8, and T1 are spared in classic Erb's, and shoulder dystocia isn't a direct cause of, say, 5–10% of neonatal seizures. That's a separate issue.
Okay, sometimes assistance is needed for vaginal delivery. Forceps, what are the absolute must-haves before using them?
Strict prerequisites. Cervix must be fully 10 centimeters dilated, membranes ruptured. You have to know the exact fetal head position.
Head engaged.
Yes, engaged, and at least at +1 station or lower. Adequate analgesia must be in place. trained staff available, empty bladder, and informed consent from the mother.
So 8-centimeter dilation is a definite no-go.
Absolutely not. Full dilation is required.
And when are forceps absolutely contraindicated?
Contraindicated for brow presentation, face presentation, and for delivering the aftercoming head in a breech birth.
What about the vacuum extractor? What are the specific dangers to the baby?
Potential risks include scalp lacerations, cephalohematoma that's bleeding under the scalp periosteum.
Subgaleal hemorrhage?
Yes, that's more serious bleeding between the scalp and skull. Also, retinal hemorrhages and neonatal jaundice can be associated.
And these are distinct from general labor risks like PPH or uterine rupture.
Correct. Those are general risks. Vacuum risks are specific to the device. However, vacuum is generally associated with less maternal morbidity compared to forceps. Fewer serious tears for the mother, usually.
Okay, tough scenario. Intrauterine fetal demise, IUFD. If a baby has died in utero at 36 weeks, is in a transverse lie, and the mother is in active labor, what's the delivery method?
In that specific situation, dead fetus transverse lie, active labor or cesarean section is the indicated mode of delivery.
What about TOLI or a trial of labor after cesarean? What helps predict success?
A big factor favoring success is having had a previous successful vaginal delivery, either before or after the C-section.
And if the reason for the first C-section was failure to progress or CPD?
That makes a successful TOLAC less likely, as the underlying issue might still be present.
Let's wrap up this section with fetal monitoring during labor. Early decelerations on the CTG.
Early decels mirror the contraction, gradual down, gradual up. Nadir matches the peak. Usually benign, caused by head compression.
I love decelerations.
Lates are more worrying. They start at or after the peak of the contraction and return to baseline after the contraction ends. They indicate uteroplacental insufficiency, potential hypoxia. Repetitive lates are a strong sign of fetal hypoxia.
Variable decelerations.
Variables are abrupt drops in returns in heart rate, varying in shape and timing relative to contractions. Very common, usually due to umbilical cord compression.
Sinusoidal pattern. Looks like a smooth wave.
Yeah, a smooth, undulating sine wave pattern. Ominous sign. Associated with severe fetal anemia, maybe from vasoprevia, abruption, or cord prolapse.
Tachycardia. Fast heart rate.
Fetal tachycardia often linked to maternal fever or infection.
And bradycardia. Slow heart rate.
Can be due to maternal hypothermia, drugs like beta blockers, fetal heart block, or prolonged hypoxia. Maternal hyperthyroidism is not a cause.
If the tracing is worrying, sometimes a fetal scalp pH is done. What are the key values?
Right. Reassuring is pH 7.25. Borderline is 7.20, 7.25, needs repeating in about 30 minutes. Critical or acidotic is 7.20, indicating significant distress.
So 7.27 is good, 7.15 is bad.
Exactly. 7.10 is definitely not reassuring.
And a positive contraction stress test, CST.
That's defined by seeing late decelerations after 50% or more of the contractions during the test period.
Okay, pain relief. Epidurals are common. When are they contraindicated?
Contraindications include hypovolemia, low blood volume, significant coagulopathy, like if the patient is anticoagulated.
Patient refusal.
Yes, refusal is absolute. Also, active infection at the insertion site or raised intracranial pressure, though pseudotumor cerebri is a specific exception there.
And absolute contraindications to any regional anesthesia, spinal or epidural.
Key absolutes are hypovolemia, infection over the site, and patient refusal. Pseudotumor cerebri is not an absolute contraindication.
Operative delivery cesarean section. What's the most common reason?
Failure to progress in labor is the most frequent indication.
Others. Fetal distress, malpresentation.
Yep. Fetal distress, malpresentation like breech or transverse, prior C-section history, placenta previa, placental abruption.
What about the classical C-section, the vertical uterine incision? When is that done?
Reserved for specific situations. Perimortem C-section, mother dying. History of a prior classical incision, some complex transverse lies where the back is down, or if doing a C-section hysterectomy for something like cervical cancer.
Fibroids aren't usually a reason for class.
Not unless they're really large and blocking the lower segment, making the usual incision impossible.
And the big concern after a classical C-section.
Much higher risk of uterine scar rupture in future pregnancies or labors.
What about assisted vaginal delivery forceps or vacuum? Indications.
Things like maternal exhaustion in the second stage, a prolonged second stage without progress, evidence of fetal distress needing expedited delivery, or certain maternal conditions like some heart diseases where prolonged pushing is discouraged.
But not for CPD or OP position.
CPD is a contraindication. Occipito-posterior position is generally only a relative indication, not an absolute one.
Last thing here, episiotomy. That's basically an intentional tear.
Essentially, yes, a surgical incision in the perineum. A medial-lateral cut bleeds a bit more initially.
But less likely to extend into the sphincter than a midline one.
That's the trade-off, yes. Lower risk of severe perineal trauma with medial-lateral compared to midline.
Okay, deep breath. Let's shift gears to antenatal care and screening. When's the ideal time for that first booking visit?
Ideally, somewhere between 8 to 10 weeks or perhaps 11 to 14 weeks. That later window, 11-14 weeks, often aligns nicely with the timing for the neutral translucency scan, part of the first trimester screening.
And a routine checkup around 28 weeks. What's typically included? Urine dipstick, BP.
Yep, urine for protein and sugar, blood pressure check, and listening to the fetal heartbeat with the Doppler.
But not routinely checking the baby's presentation at 28 weeks.
Not usually, unless there's a specific reason. Checking presentation becomes more standard later in the third trimester.
When can we first hear the heartbeat?
With a transvaginal ultrasound, you can usually detect cardiac activity around 6 weeks gestation.
For dating the pregnancy accurately, what's the gold standard?
First trimester ultrasound measurement of the crown rump length, the CRL. That's the most accurate method.
Especially useful around 9 weeks or so?
Yes, CRL is the choice then. Of course, if someone has very regular cycles, their last menstrual period, LMP, can be pretty reliable too.
And the average pregnancy length is?
280 days from the first day of the LMP.
Which leads us to Nasal's rule for calculating the EDD, the due date. How does that work again?
Simple formula. Take the first day of the LMP, subtract 3 months, and add 7 days, based on that 280-day average.
Example, LMP, May 7th.
Subtract 3 months gets you to February 7th, add 7 days, February 14th the following year.
Okay. We also measure the symphysis fundal height throughout pregnancy, if it's measuring large for dates.
Could be several things: multiple pregnancy, twins plus, polyhydramnios, too much fluid, microsomia, large baby, or simply incorrect dating.
And if it's measuring small.
Could suggest IUGR, growth restriction, oligohydramnios, low fluid, incorrect dates again, or possibly fetal demise.
We know that genesis wouldn't cause a large SFH, right? It causes low fluid.
Exactly. Renal agenesis leads to oligohydramnios, which results in a small for dates SFH measurement.
What screening tests are routinely offered during pregnancy? Down syndrome.
Yes, screening for Down syndrome and other aneuploidies, screening for infections like hepatitis B, checking rubella immunity status, and screening for risk of fetal anomalies, usually via ultrasound.
What's generally not routinely offered to everyone? Cystic fibrosis.
Right, CF screening isn't universal unless indicated by family history or ethnicity, and it's screening for risk of fetal anomalies. Diagnostic tests confirm them.
The triple screen blood test. What does that look for?
That screens for Down syndrome, Edwards syndrome, trisomy 18, and open neural tube defects, NTDs.
Low PPA on first trimester screening. What might that indicate?
Low PPA can be associated with increased risk of impending fetal death, preterm delivery, low birth weight, and IUGR, not typically associated with post-date pregnancy.
AFP testing for neural tube defects. Best timing.
Most sensitive between 16 and 18 weeks gestation.
For more definitive genetic testing, we have invasive procedures, CVS.
Chorionic villus sampling, done earlier, usually 10-12 weeks. Samples placental tissue for chromosomal analysis.
And amniocentesis.
Amnio is done later, usually after 15-16 weeks. Samples amniotic fluid, used for karyotyping, checking rhesus status, fetal infections like toxo, or assessing fetal lung maturity if needed.
Risks associated with these: miscarriage.
Yes, both carry a small risk of miscarriage. Amnio, especially if done very early, also had concerns about respiratory distress syndrome, RDS, if it leads to preterm birth. They are not associated with causing fetal postural deformities, though.
Corticosteroids like betamethasone, why are they given?
Primarily to promote fetal lung maturity, especially if there's a risk of preterm delivery, like with PPRMOM.
Let's talk Rh isoimmunization again. Rh negative mother, Rh positive baby. Does it usually affect the first pregnancy?
Not usually the first Rh positive pregnancy, unless the mother has been previously sensitized, maybe through a prior miscarriage termination or blood transfusion, without getting anti-D.
So that booking blood group screen is vital.
Absolutely crucial. If she's Rh negative and not sensitized, she gets anti-D immunoglobulin RhoGEM.
When? 28 weeks.
Typically around 28 weeks prophylactically, and then again after delivery if the baby is confirmed Rh positive. Also given after any potential sensitizing event during pregnancy bleeds, trauma, amnio, CVS.
How much fetal blood does a standard dose neutralize?
A 50 microgram dose typically covers about 5 milliliter of fetal blood exposure.
And the mechanism is maternal IgG antibodies crossing the placenta.
Yes. The mother produces IgG antibodies against the Rhd antigen. These cross the placenta and attack the baby's Rh-positive red blood cells, causing hemolysis.
And it gets worse with subsequent pregnancies.
Generally, yes, the sensitization and antibody response can become stronger with each Rh-positive pregnancy if not prevented.
But you wouldn't give anti-D at 28 weeks if she's already sensitized.
Correct. Once sensitized, anti-D is ineffective and potentially harmful. And it's not true it never affects the first pregnancy due to those prior sensitization routes.
Okay. Biophysical profile, BPP, what components does that include?
It combines a non-stress test, NST, of the fetal heart rate with ultrasound assessment of 4 parameters: fetal breathing movements, gross body movements, fetal tone, and amniotic fluid volume, AFV.
What's not part of the standard BPP? Rapid eye movements. Doppler.
Right, REM sleep isn't assessed. And while umbilical artery Doppler is often done alongside, it's technically not part of the 5 components of the standard BPP score itself.
Preconception counseling is so important. Let's take epilepsy. What's the advice?
Key things: optimize seizure control, ideally on monotherapy, lowest effective dose. Emphasize strict compliance. Crucially, prescribe high-dose folic acid 5 milligrams daily, starting before conception.
And discuss the risks of medications versus uncontrolled seizures.
Absolutely. And it's vital not to just stop meds during early pregnancy. The standard 400 micrograms of folic acid is not enough.
What about preconception advice for diabetes? What are the big risks in pregnancy?
Major risks: preeclampsia, significant risk of congenital anomalies, especially cardiac defects and neural tube defects, plus caudal regression syndrome.
Macrosomia.
C-section.
Yes, macrosomia leading to higher C-section rates. Also IUGR in some cases, preterm birth. Good glycemic control before getting pregnant is the most critical factor to reduce these risks.
Diabetes itself doesn't increase breech risk directly. Not directly, no. But factors associated with diabetes, like polyhydramnios or a large baby, might indirectly influence presentation.
Right, let's move into benign gynecological conditions.
Yeah.
Endometriosis first. What is it fundamentally?
It's endometrial tissue, the lining of the uterus found growing outside the uterus. It's estrogen dependent and causes chronic inflammation.
Where does it typically show up? Ovaries.
Very common on the ovaries, forming those chocolate cysts or endometriomas. Also the pelvic peritoneum lining, the uterus sacral ligaments behind the uterus, the pouch of Douglas.
Symptoms. Painful periods are classic, right?
Yes. Secondary progressive dysmenorrhea periods getting more painful over time. Also deep dyspareunia, pain with deep intercourse, chronic pelvic pain, infertility is common, and sometimes dyschezia, painful bowel movements, especially during periods if the bowel is involved.
Less common might be rectal bleeding.
Intermittent rectal bleeding coinciding with menses can happen if there's bowel endometriosis. The classic triad is often quoted as dysmenorrhea, dyspareunia, and less often dyschezia.
How is it definitively diagnosed?
Gold standard is laparoscopy direct visualization, often combined with biopsy of suspicious lesions for histological confirmation.
Can CA-125 blood test help?
It can be elevated, particularly with endometriomas, but it's not specific or sensitive enough for screening or reliable diagnosis on its own. Too many other things can raise it.
Infertility is a big issue. Affects what percentage?
Estimates vary, but around 30–50% of women with endometriosis experience infertility. The dossier mentions 20% in one question, but 30–50% is more widely cited.
How does it cause infertility? Adhesions.
Multiple ways. Adhesions distort anatomy. Chronic inflammation. Altered fallopian tube motility, possibly due to prostaglandins like PGF2 alpha. There might be issues with oocyte maturation, maybe luteinized unruptured follicle syndrome, altered gonadotropin surge.
Is it due to low macrophage concentration?
No, actually the opposite. The inflammation typically involves increased macrophage activity in the pelvis.
Treatment for fertility. Surgery.
Laparoscopic surgery to remove or destroy the implants, ablation excision, is often the first step if fertility is the goal.
And for pain management?
Medical options. Combined OCPs, progestins, NSAIDs for pain relief. GnRH agonists can induce a temporary menopause state, often used with add-back therapy if used long-term to protect bones. Danazol less used now. Aromatase inhibitors are sometimes used off-label.
Definitive treatment.
Hysterectomy, with or without removing the ovaries, DSO, is definitive, but obviously ends fertility.
What about those ovarian endometriomas? Does removing them affect ovarian reserve?
Yes, surgically removing endometriomas can potentially damage healthy ovarian tissue and reduce ovarian reserve. It's a balance, especially before IVF weigh the benefits of removal, if large symptomatic, against the potential impact on egg count.
Pelvic diaphragm muscles.
Levator ani.
Right, the levator ani group, pubococcygeus, iliococcygeus, puborectalis, and the coccygeus muscle, ischiooccygeus. Obturator internus is not part of the pelvic diaphragm.
Histology of endo. What do you see under the microscope? You need to see both endometrial glands and stroma outside the uterus. Often see hemosiderin-laden macrophages, too, from old bleeding. Decidual changes only happen if the woman is pregnant.
Okay, switching to uterine fibroids or lamiomas. Benign, smooth muscle tumors, right? Very common.
Extremely common. Benign, estrogen-dependent, the most common pelvic tumor overall.
Symptoms. Heavy bleeding is number one.
Menorrhagia, yes, that's the most common symptom. Also, pressure symptoms, urinary frequency, constipation if they press on the bladder or bowel. Pain, maybe dysmenorrhea or acute pain if a fibroid degenerates. Sometimes infertility or subfertility, and you might feel a palpable mass.
What symptoms are not typical of fibroids? Oligomenorrhea.
Correct. Infrequent periods, oligomenorrhea aren't typical, and they aren't usually the cause of primary dysmenorrhea.
Where can they be located? Submucosal.
Submucosal, inside the cavity, often causing bleeding. Intramural, within the muscle wall. Subserosal on the outer surface, and sometimes pedunculated on a stalk.
They can grow in pregnancy. And that
Yeah.
red degeneration thing.
Yes, they often increase in size during pregnancy due to estrogen. Red degeneration is painful infarction within the fibroid, more common in pregnancy.
Risk of becoming cancerous. Sarcoma.
Very rare. Less than 0.5% undergo sarcomatous change.
Do they cause polycythemia?
Not typically, unless maybe a huge one compresses the kidney and affects erythropoietin, but that's highly unusual.
Treatment. Medical options. GnRH analogs.
GnRH analogs can shrink them significantly, maybe 50% in 3 to 6 months, often used preoperatively, but they cause menopausal side effects.
Other options. UAE. Myomectomy.
Uterine artery embolization, UAE, blocks blood supply. Myomectomy removes the fibroids while preserving the uterus for fertility. And hysterectomy is definitive.
Some myths.
Yeah.
They don't affect only 5% of women, right? Much higher prevalence.
Much higher, yes. And
Right.
they don't always cause symptoms. Many are asymptomatic. And they have a pseudocapsule, not a true capsule.
What about adenomyosis? Endometrial tissue in the muscle wall.
Exactly. Glands and stroma within the myometrium.
Symptoms similar to fibroids. Heavy bleeding, painful periods.
Yes, menorrhagia and secondary dysmenorrhea are the main symptoms. The uterus often feels bulky, tender, and sort of globular on exam.
Diagnosis tricky without histology.
Often clinical suspicion plus imaging like MRI helps, but definitive diagnosis is histological, usually after hysterectomy.
And treatment.
Hysterectomy is definitive. Medical treatments like for endo can be tried, but are often less effective than for endometriosis itself.
Okay, polycystic ovary syndrome, PCOS. What's the classic triad?
Usually defined by 2 out of 3. 1, oligo or anovulation, or regular absent periods. 2, clinical or biochemical signs of hyperandrogenism, like the hirsutism acne. 3, polycystic ovaries on ultrasound, that string of pearls look.
Often associated with obesity and insulin resistance.
Very commonly, yes.
What are the long-term health risks? Endometrial cancer. Diabetes.
Yes, increased risk of endometrial hyperplasia and cancer due to chronic anovulation,
Yep.
increased risk of type 2 diabetes, metabolic syndrome, infertility, possibly sleep apnea, dyslipidemia, hypertension.
What's not typically increased risk with PCOS? Type 1 diabetes. Breast cancer.
Correct. No link to type 1 diabetes. And the dossier specifically flags that an increased breast cancer risk is not supported by current evidence.
Hormone profile often shows high LH-FSH ratio.
Often, yes, an LH to FSH ratio greater than 2.1 is classic but not universal. Also, often high androgens, normal or low FSH, and high estrogen levels. Insulin resistance is common, so fasting insulin might be high.
Management example. Counseling on risks. Weight loss.
Definitely counsel on the long-term risks like endometrial cancer and diabetes. Weight loss is key if overweight. Often check a glucose tolerance test, GTT. And again, important to note, not an increased breast cancer risk.
Pelvic inflammatory disease. PID. Ascending infection. Mostly chlamydia, gonorrhea.
Yes, infections spreading up from the cervix, vagina to the uterus, tubes, ovaries. Chlamydia and gonorrhea are the main culprits.
Risk factors. Multiple partners, young age, IUD.
Multiple partners, younger age at first intercourse, IUD insertion, risk is mainly around insertion time. History of prior PID. OCPs are actually protective.
Symptoms. Lower belly pain. Discharge.
Usually bilateral lower abdominal pain, abnormal vaginal discharge, sometimes fever, dyspareunia, painful sex, irregular bleeding.
Key exam finding. That chandelier sign.
Yes, cervical motion tenderness, CMT, the chandelier sign because the patient might jump. Also adnexal tenderness, pain on palpating ovary tubes.
Diagnostic criteria. Need all three.
Yeah.
Lower pain, adnexal tenderness, CMT.
Those are the minimum clinical criteria. Supporting criteria help confirm. Fever 38C, high white cells, high ESR-CRP, positive tests for CN.
Some specifics from the dossier. ESR-10 isn't high enough. WPT-15K is maybe higher than typical. Fever not always present.
Right, those details matter. ESR usually needs to be higher. WBC-10K is typical. Fever isn't always present. The bimanual exam finding those tender spots is really the most important part.
Complications are serious.
Yeah.
Infertility. Ectopic.
Big ones. Chronic pelvic pain, infertility due to tubal scarring blockage, increased risk of ectopic pregnancy, potential for tubo-ovarian abscess TOA, and Fitzhugh-Curtis syndrome, that's perihepatitis, inflammation around the liver.
Treatment. Antibiotics.
Broad-spectrum antibiotics are key. Often doxycycline plus ceftriaxone, maybe add metronidazole. Hospitalized if severe, high fever TOA.
What's not part of PID treatment? DNC, IUD removal?
No, DNC. IUD removal isn't routinely necessary if the patient is responding to antibiotics, though sometimes considered if they aren't. Cultures help guide therapy, but don't delay starting treatment.
Ovarian cysts. Functional cysts are super common, right? Follicular corpus luteum.
Very common, yes. Usually resolve on their own within 1 to 3 cycles.
So for a simple cyst, maybe 5-7 centimeters, just re-examine in 6 weeks.
Often, yes. Watchful waiting with a repeat scan is standard for simple, small, asymptomatic cysts.
Do OCPs treat existing cysts?
No, they don't shrink existing functional cysts,
Right.
but they prevent new ones from forming by suppressing ovulation.
Corpus luteum cysts. Thin-walled.
Yeah.
Can cause pain.
Yes, typically thin-walled, unilocular. Can cause some pain tenderness, maybe mess with your period, and occasionally twist, torsion. Usually resolve over weeks or a couple of months. 7-10 days might be a bit quick for full resolution.
Dermoid cysts. Mature cystic teratomas. Germ cell tumors. Common in young women.
Yes, commonest ovarian tumor in younger women. Germ cell origin, usually benign. Bilateral in about 10-15% of cases.
Treatment is usually cystectomy. Laparoscopy preferred.
Yes, surgical removal, cystectomy, preserving the ovary if possible. Laparoscopy is the preferred approach.
So not bilateral 40%. Not always oophorectomy. Not epithelial.
Correct, on all counts.
Simple 5 centimeter symptomatic cyst in a non-pregnant woman. Repeat scan in 6 weeks.
That's the standard approach. No need for immediate surgery, aspiration, or routine CA-125 testing unless there are concerning features or the patient is postmenopausal.
Okay, vulvar conditions. Bacterial vaginosis, BV, fishy odor, gray discharge, high pH.
Yep, fishy odor, thin gray discharge, pH 4.5, and those clue cells under the microscope.
Treat with metronidazole.
Yes, metronidazole is the standard treatment. BV is common, not rare, not always symptomatic, not profoundly inflammatory, and not treated with clotrimazole. That's for yeast.
Trichomonas, yellow-green frothy discharge, strawberry cervix.
Classic description. Yellow-green, frothy, causes irritation, dysuria. Strawberry cervix, petechia, sometimes seen. pH, also 4.5. See modal flagellates on wet mount.
Treat patient and partner with metronidazole.
Absolutely essential to treat both. And it definitely causes irritation.
Yeast infection, candidiasis.
Yeah.
Itching. Cottage cheese discharge.
Intense itching pruritus is key. Burning, dyspareunia sometimes. Thick, white, cottage cheese discharge. Importantly, pH is usually normal, 4.5.
Risk factors. Diabetes, antibiotics, pregnancy.
Yes, DM, antibiotics, pregnancy, OCPs, immunosuppression all increase risk. IUCD use is not a typical risk factor. Candida albicans is the usual suspect. Treat with antifungals.
Atrophic vulvitis. Due to low estrogen.
Yes. Common postmenopause. Causes dryness, itching, dyspareunia. Best treatment for the itching is topical estrogen.
Lichen sclerosis. Chronic inflammation.
Yeah.
White, thin skin.
Yes. Chronic inflammatory condition. Causes intense itching. Skin looks thin. White, crinkled cigarette paper skin. Importantly, there's an increased risk of squamous cell carcinoma, SCC.
Treatment is potent steroids, not surgery.
Correct. Potent topical steroids are first line. Surgery isn't the main treatment.
Vulvar itching can have many causes: infections, skin conditions, neoplasia.
Right. Candida, trich, lichen sclerosis, lichen planus, VIN, vulvar cancer, systemic issues, local irritants. Gonorrhea usually causes cervicitis PID, not primarily vulvar itching.
Foreign body in young girls. Foul discharge.
Yes, always consider that possibility in prepubertal girls with persistent discharge.
General vaginitis with profuse, yellow, frothy, offensive discharge. What tests?
Need to do a wet mount, KOH prep, check pH, maybe cultures to identify the cause, like trichomonas.
Pelvic organ prolapse, POP. Cystocylus bladder prolapse, common postmenopause.
Yes, bladder bulging into the anterior vaginal wall. Very common, especially after menopause and childbirth. It doesn't cause stress incontinence directly, but they often coexist. And while less common, it can occur in nulliparous women.
Uterine support levels. Level 1 is apical, cardinal uterosacral ligaments.
Correct. Level 1 provides that top support. Procedentia means complete prolapse, stage 4.
Risk factors for prolapse. Multiparity is huge.
Multiparity is a major one. Also, chronic cough, constipation, obesity, smoking, possibly collagen defects. Prior hysterectomy can sometimes weaken support. Inguinal hernia repair is not a risk factor.
Urinary incontinence, stress incontinence, SUI, leakage with effort.
Yes, leaks with cough, sneeze, exercise, often due to urethral hypermobility or sphincter weakness. Common postmenopause.
Urge incontinence, UUI, overactive bladder, OAB, urgency frequency, detrusor overactivity.
Exactly. Sudden urge, gotta go now. Freaking scene, nocturia, usually caused by involuntary bladder contractions, detrusor overactivity, often idiopathic, no clear cause. Treat with anticholinergics or beta-3 agonists.
SUI diagnosis.
Yeah.
Just history isn't enough.
Usually need history, exam, maybe urodynamics to confirm genuine SUI.
Detrusor instability, OAB treatment.
Yep.
Anticholinergics like oxybutynin.
Yes, anticholinergics are a mainstay, not treated with TVT surgery. That's for SUI.
TVT surgery can use different anesthesia types. Urodynamics often done first.
Yes, can be local, regional, or general anesthesia. Urodynamics are usually done pre-op for SUI surgery.
TVT complications. Voiding issues. Bladder perforation.
Potential issues include difficulty emptying the bladder, bleeding hematoma, bladder perforation during placement, and mesh erosion later on. Ureteric injury is less common with TVT specifically.
Okay, contraception. Combined oral contraceptives, COCPs. How do they work mainly? Ovulation inhibition.
Yes, primary mechanism is inhibiting ovulation by suppressing the LH surge. Also thickens cervical mucus and alters the endometrium. Preventing implantation is not the main mechanism.
Risk side effects. Blood clots.
ZTE. Yes, increased VTE risk, also small increased risk of MI and stroke, especially if 35 and smoking or hypertensive. Hepatic adenomas, rare, hypertension, gallstones, headaches, fluid retention, nausea can occur.
What are not typical side effects? Functional cysts, weight gain.
They actually reduce functional cysts. Loss of libido isn't consistent. Significant weight gain isn't directly proven for most modern pills.
Benefits. Cancer protection.
Reduced risk of ovarian and endometrial cancer, also reduced benign breast disease, PID, ectopic pregnancy, can improve cycle regularity, painful periods, dysmenorrhea, and acne.
But not reduce cervical cancer risk.
Correct. No protection against cervical cancer.
Contraindications. History of VTE. Migraine with aura.
Absolutely. Current past VTE, known thrombogenic mutation, history stroke, MIIHD, complicated valve disease, migraine with aura, current breast cancer, severe liver disease tumor, major surgery with immobilization, H35ND, smoking 15 cigs day, uncontrolled HTN.
So a personal DVT history is a contraindication. What about treated gallstones or uncomplicated valve disease?
Yes, personal VTE history is a contraindication. Medically treated gallstones or uncomplicated valve disease are generally not absolute contraindications.
When should you stop them immediately? New focal migraine.
Jaundice. Yes, new focal migraine, jaundice, breast cancer diagnosis, uncontrolled hypertension developing, family history of breast cancer or DVT is not a reason to stop.
Safe up to 40 for non-smokers.
Generally considered safe, yes. And remember, it's the estrogen-suppressing FSH and progestogen-suppressing LH surge that stops ovulation, not just the progestogen alone.
Progestogen-only pills, POPs, mini pill, main action, thickening mucus.
Yes, primarily works by thickening cervical mucus, also thins the endometrium. Ovulation inhibition is inconsistent.
So not primarily suppressing ovulation.
Yeah.
Not causing hyperplasia, not spermicidal.
Correct. Doesn't reliably stop ovulation, doesn't cause hyperplasia, thins lining, not spermicidal, no proven effect on libido.
Side effects. Irregular bleeding.
Irregular bleeding spotting is common. amenorrhea can occur. Functional cysts are possible. Sometimes acne, breast tenderness does not inhibit lactation, often used postpartum.
Contraindications. Breast cancer.
Current breast cancer, severe active liver disease, mild HTN, depression, migraine without aura are not contraindications.
Intrauterine devices. IUCDs. Copper IUD. How does it work? Spermicidal.
Yes, copper ions are toxic to sperm, spermicidal, inhibit sperm motility and fertilization, also creates a sterile inflammation in the endometrium. Failure rate around 1-2 per 100 woman years.
Levonorgestrel IUS, like Mirena. How does that work? Progestin effect.
Yes, releases levonorgestrel locally, thickens cervical mucus, thins the endometrium, causes light no periods, inhibits sperm function, partially suppresses ovulation, contains levonorgestrel.
Failure rate. Much lower.
Very low, around 0.2 per 100 woman years. Great for heavy bleeding, too.
Does Mirena contain desogestrel or those others? PID risk?
No, contains levonorgestrel. No increased PID risk long-term, just slightly around insertion.
Contraindications. Active PID, distorted cavity.
Yes, active PID, unexplained bleeding, significantly distorted uterine cavity, current breast cancer for the LNG-IUS, Wilson's disease, or copper allergy for the copper IUD.
History of ectopic, heart disease.
Ectopic history is a relative, not absolute, contraindication. Rheumatic valve heart disease is generally not a contraindication.
Side effects. Copper versus LNG-IUS.
Copper IUD can cause heavier, more painful periods. LNG-IUS often causes irregular bleeding initially, then light periods or amenorrhea. Hormonal side effects are less systemic with LNG-IUS.
Complications. Expulsion, perforation.
Expulsion, uterine perforation, rare, usually at insertion. Infection risk around insertion time. If pregnancy occurs, rare, higher chance it's ectopic.
Missing threads. What's the workup?
First, good look with a speculum. Gently probe inside cervix uterus. If not found, pelvic ultrasound is next. X-ray if US doesn't locate it, if perforation suspected.
Why do people usually stop using them?
Most common reasons are abnormal bleeding or pain.
Injectable progestins, Depo-Provera.
Yeah.
Side effects. Irregular bleeding, weight gain.
Yes, irregular bleeding, gonorrhea, weight gain are common. Also delayed return to fertility after stopping and potential reduction in bone density with long-term use. Doesn't flare endometriosis.
Implant and explant. Etinogestrel.
Yes, contains etinogestrel. Highly effective. Similar side effect profile to other progestogen-only methods. Irregular bleeding is very common.
Barrier methods like condoms. Lowest PID risk.
Yes, condoms offer the best protection against STIs, hence lowest PID incidence among contraceptive users.
Failure rates, typical use, roughly. COCP's low. Copper IUD, slightly higher. Mirena, very low.
COCPs maybe 0.11+%, copper IUD 1-2%, Mirena 0.2%, diaphragm much higher variable rate, maybe 115+%, vasectomy very effective 0.15%, not 0.02%. All depend heavily on correct, consistent use.
Emergency contraception options.
Levonorgestrel pill, ulipristal acetate pill, or insertion of a copper IUCD.
Okay, moving into gynecological oncology. Cervical cancer risk factors. HPV is the big one.
Absolutely. Persistent high-risk HPV infection is a major cause. Other factors: early onset of sexual activity, multiple sexual partners, smoking, immunosuppression, high parity, many births, possibly long-term OCP use, debated, low socioeconomic status.
What's not a risk factor? Frequency of intercourse. Alcohol, Mirena.
Correct. Frequency itself isn't the issue. It's partner's HPV exposure. Alcohol, not linked. Mirena is not a risk factor. Young age of first coitus IS, a risk factor.
Screenings via Pap smear.
Pap smear looks for precancerous or cancerous cellular changes, cytology. Not primarily for infection, polyps, or erosion, though those might be noted. A negative Pap doesn't 100% exclude issues.
HPV types 16 and 18 cause, in most cases, 18 more adenocarcinoma.
Yes, 16 and 18 account for about 70%. HPV 18 is more strongly associated with adenocarcinomas.
Prognosis depends most on stage.
Stage is the most important prognostic factor. Then tumor volume, lymph node status, vascular invasion, histology grade. Age is least important.
Staging is clinical, based on exam.
Primarily clinical staging, pelvic exam, possibly under anesthesia, plus imaging.
Stage IA, microinvasive. IB is visible.
Yes, IA is microscopic invasion only. IB is clinically visible or larger than IA. Stage 2 goes beyond cervix, but not to pelvic wall or third vagina. 3 reaches pelvic wall or third vagina, causes hydronephrosis. 4 invades bladder rectum or distant mets.
Treatment for stage I example, Q372, G3P340, EO, SQCCCA. Simple hysterectomy. Comb.
For IA1, simple hysterectomy or conization, if fertility desired, are options. The dossier answer B, TAH plus BSO plus ovarian translocation seems unusually aggressive for standard IO1. Radical hysterectomy is for stages like IB1IA.
How does cervical cancer present? Bleeding after sex?
Postcoital bleeding is classic. Also, intermenstrual bleeding, persistent abnormal discharge. Late symptoms can include pain, urinary or bowel issues.
Cervical ectropion. Benign. Columnar cells.
Benign finding, columnar epithelium on the ectocervix. Often asymptomatic, can cause postcoital spotting or discharge. It's columnar, not squamous. Treat with cryoablation only if symptomatic.
Endometrial cancer. Most common gynae cancer in developed countries.
Yes, it is. And Jordan, according to Q236.
Risk factors driven by unopposed estrogen. Obesity. PCOS. Tamoxifen.
Exactly. Unopposed estrogen is key. So obesity, peripheral conversion, chronic anovulation, PCOS, tamoxifen use, estrogen-only HRT, also nulliparity, early menarche, late menopause, diabetes, hypertension, Lynch syndrome.
Highest risk among options like obesity versus having many kids.
Obesity and nulliparity carry significant risk compared to high parity. Example, 5+ children.
What's not a risk factor? Combined HRT, OCPs, smoking.
Combined HRT, E plus P is protective. OCPs are protective. Smoking might actually be slightly protective, though bad for other reasons. Late menarche, early menopause are not risk factors. Fibroids are not a risk factor.
Presentation. Postmenopausal bleeding is key.
Postmenopausal bleeding, PMB is the cardinal symptom, must be investigated. Irregular bleeding in perimenopausal women also warrants investigation.
Diagnosis in endometrial biopsy, DNC, ultrasound.
Endometrial biopsy, PIPEL is common, or DNC for tissue diagnosis. Transvaginal ultrasound, TVUS, is useful for PMB, endometrial thickness. 4-5 mm needs biopsy. Thickness of 10 mm in PMB is highly suspicious.
Type I versus type 2, estrogen-driven versus not.
Type I endometrioid is commonest, 80%. Estrogen-related, arises from hyperplasia, better prognosis. Type 2, serous clear cell carcinosarcoma, not estrogen-driven, arises in atrophy, poorer prognosis.
Staging is surgical, hysterectomy, BSO, nodes.
Yes, surgical staging, TAH plus BSO plus lymphadenectomy, pelvic plus periaortic plus peritoneal washings.
Stages, I in uterus, 2 cervix, 3rd local spread, 4 distant.
Roughly, yes. I confined to uterine corpus, 2 invades cervical stroma, 3 local regional spread, serosa, adnexa, vagina nodes, 4 bladder bowel mucosa or distant mets.
Prognosis depends most on stage. Grade, depth.
Stage is #1, then grade, depth of myometrial invasion, LVSI, lymphovascular space invasion, histological type, peritoneal cytology results.
Management example, Q483, while diff endometrioid limited to endoglands. Stage IBA.
Likely stage IA or IB if limited like that. Initial treatment is surgeon staging, TA plus BSO. Adjuvant treatment, like Vault radiotherapy, depends on final pathology and risk factors, grade, depth, LVSI. If stage 2, cervical stromal invasion, adjuvant RT more likely.
When is full surgical staging noted?
Yep.
High grade, deep invasion.
Indicated for grade 3 tumors, serous clear cell types, deep myometrial invasion, 50%. Not usually needed if distant mets are already proven.
Ovarian cancer, mostly epithelial, 90%.
Yes. Epithelial ovarian cancer, EOC, is the vast majority. Other types are germ cell tumors and sex cord stromal tumors.
Epithelial types resemble other tissues, serous like tube, mucinous like cervix.
Right. Serous fallopian tube, mucinous endocervix, endometrioid endometrium, clear cell, Brenner urothelium, bladder lining. Most common is high-grade serous, thought to often start in the tube.
Risk factors, age, nulliparity, family history, BRCA.
Increasing age, nulliparity, early menarche, menopause, family history, BRCA12, Lynch syndrome, infertility history. Maybe fertility drugs, maybe talc, controversial. Low parity is not a risk factor, nulliparity is. High BMI is weak link. Estrogen replacement data is conflicting. OCPs are protective.
Symptoms are vague, late presentation, bloating, pain.
Very vague often. Bloating, pelvic abdominal pain, feeling full quickly, early satiety, urinary symptoms, frequent urgency. Later, ascites palpable mass. Chest pain is uncommon. Met.
Screening, no effective population screening.
Correct. No proven effective screening test for the general population. CA1045 plus TVUS used for high-risk women.
CA125, elevated in 80% EOC, but also benign conditions.
Yes, elevated in about 80% EOC, but lacks specificity. Can be raised in fibroids, endo, PID, pregnancy, liver disease, etc.
Not AFP, not CA15.3, HE4.
AFP is for germ cell tumors, CA15.3 for breast cancer. HE4 is another marker, sometimes used with CA125 in the Roma score to assess risk.
Staging is surgical. TAHBSO omentectomy nodes.
Comprehensive surgical staging, TAH, BSO, omentectomy, pelvic para-aortic lymphadenectomy, peritoneal washings, multiple biopsies.
Low-risk criteria for early stage. Stage IAIB, grade 12, intact capsule.
Yes, low-risk stage I includes IAIB grade 12, intact capsule, no tumor on surface, negative washings, deployed DNA content. Ascites would not be low risk.
Management example, Q340 bilateral masses, ascites, a mental cake, stage 3.
That sounds like advanced disease, likely stage 3 EOC. Treatment is typically surgical debulking, followed by platinum-based chemotherapy.
Pseudomyxoma peritoneae, jelly belly, from appendix usually.
Often originates from a mucinous tumor of the appendix, sometimes ovary. Fills the abdomen with gelatinous material. Vulvar cancer. Mostly squamous cell carcinoma, SCC.
Yes, SCC is the main type.
Risk factors.
Yeah.
HPV in younger women. Lichen sclerosis in older. Smoke.
Yeah. HPV, often type 16, 18, 33, more common in younger women. Chronic inflammation like lichen sclerosis, smoking, immunosuppression, more common in older women.
Presentation. Itching is most common. Lump. Ulcer.
Persistent pruritus is the most common symptom, also a lump, sore, ulcer, bleeding, or pain.
Staging is surgical. Example Q440, 3 centimeter, right? Labia majora mod diff, SEC, no nodes. Stage IB.
Yes, staging is surgical. A 3 centimeter tumor confined to vulva would likely be stage IB. Tumor 2 centimeter or stromal invasion 1 millimeter confined to vulva perineum.
Treatment. Radical local excision. Modified radical vulvectomy plus nodes.
Standard used to be radical vulvectomy plus bilateral groin node dissection. Now, often modified radical vulvectomy or radical local excision with ipsilateral inguinal node dissection for unilateral lesions, aiming to reduce morbidity like lymphedema. The modification isn't just about RT need or hospitalization length itself, it's about reducing long-term side effects.
Gestational trophoblastic disease, GTD.
Yeah.
Vitatiform molde will complete versus partial.
Right. Complete mole, diploid, all paternal DNA, no fetal parts, higher risk of progressing to malignancy, GTM. US shows snowstorm HCG very high. 46XX most common. Partial mole, triploid, fetal parts present, lower GTN risk. Uterus less likely to be large for dates.
Presentation. Vaginal bleeding. Large uterus. Hyperemesis.
Vaginal bleeding commonest. Uterus large for dates. F. Complete mole. Severe nausea vomiting. Hyperemesis. Early onset preeclampsia. 20 WKs. Sometimes hyperthyroidism. Like a lutein cysts on ovaries. Least likely presenting feature might be nervousness, anorexia, tremors, less common hyperthyroid symptom.
Management. Suction evacuation follow HCG.
Yes, primary treatment is suction evacuation DNC, then meticulous beta HCG follow-up is crucial weekly until normal by 3, then monthly by 6 months.
Contraception vital during follow-up. OCPs, okay.
Absolutely vital to avoid pregnancy-confusing HCG levels. OCPs are safe once HCG is normal.
Diagnosis example. Q141, Q455 amenorrhea, NV, spotting large uterus, snowstorm US, HCG 150K.
Classic molar pregnancy. Treat with suction evacuation.
GTN is the malignant form. Persistent mole, choreo.
Yes, gestational trophoblastic neoplasia, GTN, includes persistent invasive mole, choriocarcinoma, and PSTT, placental site trophoblastic tumor, diagnosed by plateauing or rising HCG after evacuation.
Risk factors for GTN after mole. High HCG, large uterus, age 40.
Yes, very high pre-evacuation HCG, large uterus, large the Caletin cyst, 6 centimeters, maternal age 40, history of previous mole.
Poor prognosis factors for GTN itself.
Yeah.
Age 40, high HCG, long interval, brain liver mets.
Yes, age 40, not T39, initial HCG 100K, interval 4 months from the pregnancy event, antecedent term pregnancy, worse than mole abortion, brain or liver mets, failure of prior chemotherapy.
Treatment is chemo. Highly curable.
Yes, chemotherapy, methotrexate, or combination regimens. GTN is generally highly curable, even with metastases.
Choriocarcinoma, malignant, can follow any pregnancy. Mets early.
Highly malignant and can follow mole, abortion, ectopic, or term pregnancy. Metastasizes early, hematogenously. Lungs are the most common site.
Wow, that's a lot on oncology. Let's switch to pregnancy complications. Miscarriage main cause in first trimester. Chromosomes.
Chromosomal abnormalities are the most common cause, yeah. Responsible for about 50% of first trimester losses. Autosomal trisomies are the most frequent specific type.
Other causes. Maternal factors like infection, endocrine, uterine issues.
Yes. Maternal infections, poorly controlled endocrine disorders, diabetes, thyroid, uterine anomalies, septum, fibroids, thrombophilias, cervical incompetence can all contribute. Environmental factors, too.
Are structural anomalies more common than numerical chromosome issues? Parents usually have abnormal chromosomes.
No, numerical chromosomal issues, like trisomies, are more common in first trimester loss than structural fetal anomalies. And usually the parents have normal chromosomes. The error occurs sporadically in the egg or sperm or early embryo.
Incomplete miscarriage criteria: bleeding, past tissue, open cervix.
Yes. Typically vaginal bleeding, history of passing some tissue, ongoing pain cramping, cervix is open on exam, and ultrasound shows retained products of conception in the uterus. An empty uterus suggests complete or missed, not incomplete.
Septic miscarriage orgasms: polymicrobial, E. coli, bacteroids.
Usually polymicrobial E. coli, bacteroides, strep species, sometimes staph, Clostridium welkii can cause gas gangrene. Dossier notes staph is an exception in 1Q, maybe meaning less common. Usually ascends from lower genital tract, often after instrumentation.
Recurrent miscarriage,
Copper.
losses,
Yeah.
parental chromosomes, uterine antiphospholipid syndrome.
Investigate parental karyotypes, uterine anatomy, HSG cynohistro, antiphospholipid antibodies, endocrine issues. DM, thyroid. Cervical incompetence is harder to diagnose. Thrombophilies are debated, but sometimes tested. Pituitary microadenoma is not a recognized cause.
Ectopic pregnancy, implantation outside the uterus, most common site.
Ampulla of the fallopian tube is the most common site, yes.
Risk factors: previous ectopic, PID, tubal surgery, IUD.
All those increase risk. Previous ectopic is the biggest risk factor. PID causes tubal damage. Prior tubal surgery. IUD in situ. If pregnancy occurs with IUD, higher chance it's ectopic. Assisted reproduction, ART-IEVF.
Smoking. OCPs are protective, right? Not a risk factor.
Correct. COCPs reduce the overall risk of pregnancy, including ectopic.
Presentation: missed period, bleeding, pain. Rupture signs:
Classic triad. Amenorrhea, vaginal bleeding spotting, lower abdominal pain, often unilateral. Rupture leads to severe pain, possible shoulder tip pain, referred diaphragmatic irritation, signs of shock, dizziness, tachycardia.
Incidence is increasing. DES exposure is a risk.
Incidence has increased. DES exposure is a risk factor via uterine-tubal anomalies. Most are not fimbrial, usually not febrile unless complicated.
Methotrexate treatment works how? Inhibits DNA.
Yes, it's a folate antagonist, inhibits DNA synthesis in rapidly dividing cells, like the trophoblast, not RNA.
The differential diagnosis for early pregnancy pain: miscarriage, corpus luteum cyst.
Definitely miscarriage, threatened, incomplete, ruptured hemorrhagic corpus luteum cyst. Also, non-gynae things like appendicitis, UTI, gynae things like ovarian portion, fibroid degeneration. Ovarian malignancy or acute PID are less likely to present just as early pregnancy pain.
Preterm labor, PTL, before 37 weeks. Risk factors: previous PTL, multiples, infection.
Huge risk factors. Prior preterm birth is the biggest predictor. Multiple gestation. Infections, UTI, BV, chorioamnionitis, PP-PROM, cervical incompetence, short cervix, uterine anomalies, polyhydramnios, low socioeconomic status, smoking, stress.
What's the least common emergency cause among those? Cervical incompetence.
Cervical incompetence often presents more gradually, though can lead to rapid delivery. Uterine anomalies, less likely emergency causes. The pathways involve infection, inflammation, stretch, placental issues, stress. Iudroligo are associated but not direct initiating pathways.
Predicting PTL, history, cervical length, fibronectin.
History, prior PTL, is key. Transvaginal ultrasound measurement of cervical length is predictive. Fetal fibronectin, FFN, test, a negative result is very reassuring, high negative predictive value. Serial hormone levels or fetal breathing are not used for prediction.
Management: tocolytics, steroids, mag sulfate.
Tachylysis, drugs to stop contractions temporarily, like nifedipine, atosiban, maybe magnesium sulfate or indomethacin before 32 WKs. Crucially, antenatal corticosteroids, betamethasone and dexamethasone, between 24-34 weeks for fetal lung maturity, magnesium sulfate for fetal neuroprotection at 32 weeks, GBS prophylaxis if needed.
Safe tocolytics include methergine is not one.
Safe options include beta agonists, less used now, MGSO4, calcium channel blockers, nifedipine, oxytocin antagonists, atosiban, COX inhibitors, indomethacin 32 WKs. Methergine is a uterotonic used for PPH, absolutely not for tocolysis.
Fetal fibronectin, glycoprotein positive test means negative.
Glycoprotein, normally low mid-pregnancy, rises near term. Positive FFN 22 weeks suggests 40% risk of PTL soon. Negative FFN means 1% chance of delivery next 1-2 weeks. Not abnormal if positive before 20 weeks.
PROM versus PPROM. Rupture of membranes before labor.
PROM is rupture 37 weeks before labor starts. PPROM is rupture 37 weeks.
Management of PPROM at, say, 36 weeks, Q574. Induce.
At 36 weeks, induction of labor is often recommended. Risks of expectant management infection generally outweigh risks of near-term delivery. Conservative management for a full week isn't typical then. Immediate CS only if indicated. Fluid replacement doesn't stop labor.
Placenta previa, low implantation covering cervix, risk factors. Prior CS, multiparity.
Yes, placenta implanted low, over or near the internal os. Risk factors. Previous C-section, risk increases with number, multiparity, advanced maternal age, multiple gestations, smoking, prior previa, prior uterine surgery DNC. Not nulliparity, not congenital uterine anomalies, not malposition itself.
Presentation. Painless bright red bleeding after 20 weeks.
Classic presentation. Painless, bright red vaginal bleeding, usually second or third trimester.
Diagnosis. Ultrasound. TVUS is okay.
Ultrasound confirms it. Transvaginal ultrasound TVUS is safe and more accurate than transabdominal for visualizing the lower segment.
Associated risks. Malpresentation. PPH.
Yes. Associated with malpresentation, breech transverse, PPH, lower segment doesn't contract well, IUGR, PTL, complicates maybe 1 in 200, 400 pregnancies. Management depends on gestation bleeding, often needs C-section.
Low-lying at 20 weeks often moves up.
Yes, asymptomatic low-lying placenta at mid-gestation often appears to migrate up as the lower segment develops. Reassure and repeat scan later.
Example Q170, 37 WKs, painless bleed, 3 pads, stopped, stable, likely previa, next step.
Highly likely previa. Next step must be ultrasound. Absolutely NO vaginal or speculum exam until previa is ruled out.
Placental abruption, premature separation of placenta, risk factors, hypertension, trauma, smoking.
Yes, premature separation of a normally sighted placenta, risks to HTN, chronic or preeclampsia, trauma, smoking, cocaine use, PP-ROM, prior abruption history, possibly thrombophilias, though factor V listed as not risk in Q129, check that. Rapid uterine decompression, FIRG after first twin delivery. Low BMI, IVF itself usually not risks. Primary cause often unknown, peaks maybe 24, 26 WKs or 30, 32 WKs.
Presentation, painful bleeding, tender uterus, fetal distress.
Often painful vaginal bleeding can be concealed. Uterine tenderness, rigidity, woody feel, fetal distress, or demise.
Complications, shock, DIC, renal failure, cuvulaire uterus.
Maternal, hemorrhagic shock, DIC, renal failure, ATN. Sheehan's syndrome, pituitary necrosis. Cuvulaire uterus, blood in myometrium. Fetal distress demise, PTL. Uterine rupture is least likely complication of abruption itself.
Management Q268, 36 WK, shock, bleed, rigid uterus, fetal death.
Yes.
Resuscitate, deliver.
Yes, immediate resuscitation. Fluids, blood, stabilize mother, prompt delivery. If mother stable and fetus deceased, vaginal induction, including amniotomy, might be possible. If mother unstable or fetus alive and distressed, C-section usually needed. Starting with amniotomy, ARM, can help induce augment labor if vaginal delivery planned.
Vasoprevia, fetal vessels exposed over cervix, rupture risk.
Yes. Fetal vessels running in the membranes over the cervix, unprotected by cord or placenta, high risk of rupture causing rapid fetal exsanguination. Management is elective C-section before labor rupture.
Placenta accreta spectrum, abnormal adherence, accreta, increta, percreta.
Right. Accreta, superficial attachment to myometrium. Increta invades into myometrium. Percreta invades through myometrium, possibly into bladder bowel.
Risk factors, prior CS previa.
Major risk factor is prior C-section, especially combined with current placenta previa. Also prior uterine surgery DNC, advanced maternal age.
Diagnosis, ultrasound, best test.
Ultrasound is the primary tool, often with Doppler. MRI can supplement. Best initial primary is ultrasound.
Management, often planned C-section hysterectomy.
High PPH risk.
Yes, often requires a planned cesarean hysterectomy around 34-36 weeks to control the massive PPH risk.
Example Q718, previa, CS, bluish tissue, adherent uterus bladder, percreta.
That description strongly suggests placenta percreta invading the bladder.
Multiple gestation risks. Preterm labor is most common.
Yes, PTL is the biggest risk. Also higher risk of preeclampsia, GDM, discordant IUGR, congenital anomalies, cord accidents, twin-twin transfusion syndrome, TTTS in monochorionic twins.
PPH, malpresentation, C-section. Yes, increased risk of PPH, malpresentation, higher C-section rate. GDM risk is increased, but not pre-existing DM itself. IUGR risk, IS increased, especially discordant growth.
Chorionicity matters hugely. Monochorionic higher risk? How to tell?
Chorionicity is key. Monochorionic, shared placenta, twins have higher risks, like TTTS. Determined by early ultrasound, first year, early second trimester. Look for number of placentas, membrane thickness, lambda sign, DD or T sign, monodi.
Monoamniotic, monochorionic, MOMO, highest risk, cord entanglement, division day.
Highest risk due to cord entanglement, share sac and placenta. Zygote division day, 9-12.
Amniotic, monochorionic. Demo, shared placenta, separate sacs, TTTS risk. Division day.
Yes, demo, cleavage day, 4-8. Risk of TTTS, always monozygotic.
Amniotic, dichorionic, BD, separate sacs, separate placenta, division day, dizygotic.
Gadidi can be monozygotic, division day 0-3, or dizygotic, 2 eggs fertilized.
Yeah.
Dizygotic are always DD. DD is more common than MOMA.
Twin delivery mode. Depends on twin 1.
Yes, depends mainly on presentation of twin 1, gestational age, estimated weights, provider experience. Vaginal delivery often possible if twin 1 is cephalic. Second twin might need vacuum or breech extraction. PPH risk increased after delivery.
Post-term pregnancy, 42 weeks. Risks: macrosomia, shoulder dystocia, meconium aspiration.
Yes, increased risk of large baby macrosomia leading to shoulder dystocia, meconium aspiration syndrome, oligohydramnios, fetal distress or IUFD, higher rates of operative delivery, PPH, perineal trauma from mother. Failure of induction is not a complication of being post-term itself.
Complication: post-maturity syndrome, wrinkled baby.
Yes, baby may look wrinkled, have long nails, decreased subcutaneous fat, sometimes meconium staining.
Intrauterine growth restriction, IUGR. Weight 10th percentile.
Yes.
Causes: maternal placental fetal.
Yes, EFW 10th centile causes. Maternal, HTN, smoking, malnutrition, drugs, infection, placental insufficiency, infarcts, previa abruption, fetal chromosomal structural anomalies, infection. Controlled diabetes usually causes macrosomia, not IUGR.
Assessment: serial ultrasounds. Doppler.
Serial ultrasounds monitoring growth, ACS sensitive, EFW estimation. Doppler studies of umbilical artery, middle cerebral artery, MCA. Ductus venusus give info on fetal well-being, placental function.
Neonatal complications.
Yeah.
Hypoglycemia, hypothermia.
RDS.
Yes, hypoglycemia, hypothermia, polycythemia, increased risk RDS, often due to associated prematurity, NEC, long-term neurodevelopmental issues. Q134 notes RDS as exception, may be context-dependent as prematurity is linked. Adult atherosclerosis linked to low birth weight generally.
Management example, Q199Q18, 32WK, severe IUGR, normal AFI. Priority.
Priority is often to exclude underlying fetal causes like chromosomal issues or infection, especially if anatomy scan was normal. GDM causes large babies.
Oligohydramnios.
Right.
Low fluid, AFI5 or SDP2. Causes, PROM, UPI, renal agenesis.
Yes, PROM, uteroplacental insufficiency, UPI, bilateral renal agenesis, Potter syndrome, posterior urethral valves, PUV, severe IUGR.
Not duodenal esophageal atresia, those cause poly.
Correct. Those GI obstructions typically cause polyhydramnios due to impaired swallowing. Key 355 asks, what's not associated caused by oligo? Chronic leak, renal agenesis, pulmonary hypoplasia, UT obstruction, UPI are associated. Pulmonary hypoplasia is a result of prolonged oligo. Maybe the question is phrased awkwardly.
Could be. Leak causes oligo. Renal agenesis causes oligo. Obstruction causes oligo. UPI causes oligo. Pulmonary hypoplasia results from oligo. Need to see the exact phrasing options.
Polyhydramnios, too much fluid, AFI24 or SDP8, causes maternal DM, multiples. Fetal anomalies.
Yes, maternal diabetes, multiple gestation, fetal anomalies, especially GI obstructions like esophageal duodenal atresia, NTDs affecting swallowing, neuromuscular disorders affecting swallowing, fetal hydrops, placental chorioangioma, idiopathic is commonest overall.
Not polycystic kidneys, muscular dystrophy.
Fetal polycystic kidney disease usually causes oligo or normal fluid. Fetal muscular dystrophy is variable. Some types affect swallowing leading to poly, others might not. Need specifics.
Hypertensive disorders. Chronic HTN before 20 weeks. Risks.
PEP over T90 before 20 weeks or pre-pregnancy. Risks. Superimposed preeclampsia, IUGR, placental abruption, preterm delivery, not previa.
Gestational HTN. After 20 weeks, no proteinuria.
Correct. New onset HTN after 20 weeks without proteinuria or other preeclampsia features.
Preeclampsia, PET. HTN after 20 weeks, PLSS proteinuria.
Yes. 1490 after 20 weeks plus proteinuria, 300 mg 24 had, or PCR 030 or dipstick or 1.
Severe features. BPO RIS 1010N. Low platelets. High LFTs.
Yes. Severe BPO 16 or 110 or platelets 100K or elevated liver enzymes, Astalt 2XULN, or rising creatinine, pulmonary edema, cerebral visual symptoms, headache, scutomata, epigastric RUQ pain.
Risk factors for PET. Null parity, previous PET, family history, chronic HTN, DM, obesity, multiples, molar.
All are risk factors. Also renal disease, thrombophilia APS, advanced maternal age 40.
Not multiparity, not polyhydramnios, not history macrosomic baby.
Correct. Multiparity is protective. Polyhydramnios isn't a primary risk factor. History of macrosomia isn't a risk factor.
Complications.
Right.
Maternal, eclampsia, stroke, liver renal failure.
Fetal.
IUGR, preterm abruption.
Yes, serious risks for both. Maternal, eclampsia, stroke, liver rupture failure, renal failure, DIC, PPH, death. Fetal, IUGR, preterm birth, placental abruption, oligohydramnios, IUFD.
Management. Delivery is definitive cure. Antihypertensives. Magnesium.
Delivery is the only definitive cure. Antihypertensives, labetalol, hydralazine, nifedipine, used to control severe HTN to prevent stroke. ACE-IA-ARBs are contraindicated. Magnesium sulfate is crucial for seizure prevention treatment in severe preeclampsia.
Drug of choice for eclampsia severe pete seizure prophylaxis.
Magnesium sulfate, no question.
Magnesium toxicity signs. Loss of reflexes first. Respiratory depression.
Yes, loss of deep tendon reflexes, DTRs, is usually the first sign. Then respiratory depression, low urine output, flushing, ultimately cardiac arrest. Antidote is calcium gluconate. Need to lower dose, reflexes lost, respirate drops, or oliguria develops. Hyperreflexia is a sign of PET itself, not toxicity.
HELP, major cause of maternal death. Cerebral hemorrhage. Liver rupture.
Yes, those are the big life-threatening complications of HELP.
Eclampsia is just seizures on top of P.
Yes, seizures in the context of preeclampsia.
Diabetes in pregnancy.
Yeah.
Gestational, GDM. Diagnosed during pregnancy. Risks.
Yes, GDM first diagnosed in pregnancy, risks for baby, macrosomia, shoulder dystocia, neonatal hypoglycemia, maybe stillbirth. Maternal risks, ET, C-section, future type 2 DM.
Management. Diet. Metformin insulin. Screen win.
Diet, exercise first. May need metformin, glyburide, or insulin if target's not met. Screen universally around 24-28 weeks.
Risk factors for GDM. Previous GDM. Obesity. Family history. PCOS.
Yes, prior GDM, obesity, family history DM, previous macrosomic baby, PCOS, advanced maternal age, high BMI at booking IS, a risk factor, despite dossier Q exception.
Pre-existing diabetes, type 12, higher risks than GDM, congenital anomalies.
Yes, much higher risks,
Yeah.
especially congenital anomalies, cardiac VSDTGA, NTDs, caudal regression syndrome is specific, also
God.
miscarriage, glucose crosses placenta. Insulin needs typically increase significantly during pregnancy, then drop sharply postpartum. Insulin doesn't cross placenta, but glucose does freely, fetal hyperinsulinemia, macrosomia, hypoglycemia, not associated with increased Downs risk. Tight preconception control is vital.
Thyroid disease, hypothyroidism.
Yeah.
Risks. Treat. Monitor.
Increased risk miscarriage, PET, PTL, LBW, potential neurodevelopmental issues for baby. Treat with levothyroxine, dose usually needs increasing. Monitor TSH primarily.
Hyperthyroidism, Graves. Risks. Treat. Monitor.
Risks miscarriage, PTL, IUGR, thyroid storm, rare but dangerous. Treat with PTU, propylthiouracil, often preferred in first trimester, then methimazole, carbimazole later. Aim for free T4, T3 in high normal range. Surgical treatment not usual in pregnancy. Diagnosed with free hormone as TSH, not total T4, TBG increase effects total. Graves is IS, the cause 90% of time. Fetal effect usually tachycardia, not bradycardia. Maternal T4 crosses poorly early, total hormones up due to TBG, increased iodine needed.
Cardiac disease. Physiological changes.
Yeah.
Increased CO, HR, volume. Decreased SVR, BP.
Yes, cardiac output, heart rate, stroke volume, blood volume all increase significantly. Systemic vascular resistance and blood pressure decrease. BP nadir mid-pregnancy. Systolic flow murmur, common benign.
Not diastolic murmur. Not BP up in third try. Not plasma volume down.
Correct. Diastolic murmur always abnormal. BT usually returns towards baseline in third try, but shouldn't exceed pre-preg levels significantly without pathology. Plasma volume increases hugely. RBC mass increases too, but less than plasma volume, hemodilution.
High-risk conditions. Contraindications to pregnancy. Pulmonary HTN. Severe ASMS Marfan.
Absolute contraindications include pulmonary hypertension, severe symptomatic aortic or mitral stenosis, Marfan syndrome with dilated aorta, 4 to 4.5 centimeters, Eisenmenger syndrome.
Management. Multidisciplinary. Avoid exertion. Vaginal delivery preferred.
Yes, team approach, OB, cardiology, anesthesia. Avoid excessive exertion or weight gain. Manage fluids carefully. Maybe antibiotic prophylaxis for valves. Vaginal delivery generally preferred, often with assisted shortened second stage. Epidural helpful. Labor not necessarily induced early unless specific indication. Mitral stenosis is commonest acquired lesion.
Thrombophilia. Increased VTE risk. Adverse pregnancy outcomes. Treat with LMWH.
Yes, inherited or acquired thrombophilias increase risk of VTE, DVT-PE, recurrent miscarriage, IUGR, PE, abruption, often managed with prophylactic or therapeutic low molecular weight heparin LMWH.
Amniotic fluid embolism, AFE, rare, catastrophic, sudden collapse, hypoxia, DIC.
Yes, rare but devastating. Sudden onset cardiorespiratory collapse, hypoxia, hypotension, coagulopathy, DIC during labor, delivery, postpartum. High mortality. Diagnosis is clinical.
Not easily diagnosed. Not always fetal death. Maternal tachycardia causes DIC.
Correct. Diagnosis of exclusion, hard to confirm definitively. Fetal outcome poor but not always immediate death. Maternal state usually involves tachycardia, shock, not preceded by constant pain. Causes profound hypofibrinogenemia.
Sudden postpartum collapse differential, hemorrhage, AFE, PE, eclampsia.
Key causes: massive PPH, AFE, pulmonary embolism, eclampsia, anesthetic complication, for example, high spinal, cardiac event, MI, arrhythmia, cardiomyopathy. Ruptured ectopic is not a postpartum cause.
Okay, infertility and reproductive endocrinology. Definition of infertility.
Failure to conceive after 1 year of regular, unprotected intercourse.
Causes: male factor, ovulatory, tubal, uterine. Unexplained percentages roughly.
Male factor 30-40%, ovulatory dysfunction 25-30%, tubal factor 20-30%, uterine peritoneal factors 10%. Men, unexplained 10-15%. Often multifactorial.
Ovulatory dysfunction. PCOS is the most common cause of an ovulation.
Yes, PCOS accounts for maybe 80-90% of anovulatory infertility. Other causes: hyperthalamic amenorrhea, stress, weight loss, exercise, hyperprolactinemia, premature ovarian insufficiency, POI, thyroid issues, anovulation common in irregular adolescent cycles too.
Male factor assessed by semen analysis. Oligo, asthenoteratosphermia.
Yes. Oligospermia, low count. Asthenozoospermia, low motility. Teratozoospermia, abnormal morphology. Normal assay doesn't rule out all male issues. Variability exists. Consider retrograde ejaculation, especially in diabetics.
Tubal factor, often due to PID. Surgery, endo, how to assess.
Often history of PID, pelvic surgery, endometriosis. Assessed with hysterosalpingogram, HSG, or laparoscopy and dye test. HSG can show hydrosalpinx or blockage.
Uterine factors, fibroids, polyps, Asherman's, congenital.
Submucosal fibroids, endometrial polyps, intrauterine adhesions, Asherman's syndrome, congenital anomalies, septate bicornuate uterus. Asherman's often follows DNC post-miscarriage or postpartum.
Initial assessment includes history, semen analysis, ovulation check.
Yes, comprehensive history from both partners, semen analysis, confirmation of ovulation, e.g. mid-luteal progesterone, cycle tracking, possibly an HSG early on depending on history.
Right.
Mid-luteal progesterone is recommended.
Ovarian reserve test, day 3, FSHE2, AMH, AFC.
Yes, day 3 FSH and estradiol. Anti-Mullerian hormone, AMH, is considered the best single blood test. Antral follicle count, AFC, on ultrasound.
Endometriosis and infertility. We covered mechanisms. Tubal patency doesn't rule out issues.
Correct. Even if tubes are open on HS-GLAP, endo can affect function, fertilization, implantation.
Ovulation induction drugs.
Yep.
Clomiphene, first line for PCOS. Letrozole, gonadotropins.
Clomiphene SERM, traditionally first line for PCOS and ovulation. Letrozole, aromatase inhibitor, increasingly used, often now preferred first line for PCOS. Gonadotropins, injectable FSH plus LH, used for hypothalamic amenorrhea, hypogonadotropic hypogonadism Q257, or if clomiphenylletrozole fail.
When is IVF indicated? Severe tubal male factor, failed OI.
Yes, IVF for severe tubal disease, severe male factor, failed ovulation induction, unexplained infertility after simpler treatments, need for PGD, pre-implantation genetic diagnosis. Endometrioma is often removed prior if large symptomatic.
Hypogonadotropic hypogonadism, low FSH-LH, low estrogen.
Causes.
Treatment, yes, low gonadotropins, low estrogen. Caused by hypothalamic issues, Kalman's, anorexia, stress, or pituitary failure. Treat with pulsatile GnRH if hypothalamus intact, or injectable gonadotropins, FSH plus LH. Kalman's, anosmia plus amenorrhea. Not precocious puberty, not GnRH overproduction.
Amenorrhea primary, no period by 15. Causes. Turner's, malarianogenesis, AIS.
Primary. No menses by 15 or 13 if no secondary sexual characteristics. Commonest cause with high FSH is gonadal dysgenesis, Turner 45XO. Malarianogenesis is 46XX. Normal hormone is ovaries, absent uterus upper vagina. Androgen insensitivity syndrome, AIS, is 46XY. Female phenotype, absent uterus, testes present. Also hypothalamic pituitary causes.
Amenorrhea secondary. Cessation after starting, most common cause. Cessation 3 to 6 months. Most common cause by FR is pregnancy. Others: PCOS, hypothalamic, hyperprolactinemia, POI, Asherman's, thyroid disease, prolactinoma, Sheehan syndrome, postpartum pituitary necrosis after PPH.
Adolescent amenorrhea, commonest pathologic cause, commonest overall.
Most common pathologic cause is anorexia nervosa. Most common overall cause, including physiologic, is hypothalamic immaturity of the HPO axis.
Turner syndrome, 45XO.
Yeah.
Features: short web neck, streak gonads, high FSH.
Yes, short stature, web neck, shield chest, streak gonads, primary amenorrhea, infertility, high FSH-LH. Associated issues: coarctation of aorta, bicuspid aortic valve, horseshoe kidney, hypothyroidism. Intelligence, usually normal. Need estrogen for puberty bones. Can present with cystic hygroma prenatally. Incidence does not rise with maternal age.
Androgen insensitivity syndrome, AIS. Complete. 46XY. Female outside, absent uterus, testes, hair.
46XY karyotype. Female external genitalia, blind vaginal pouch, absent uterus tubes due to MIF from testes. Testes present, intra-abdoinguinal, make testosterone peripheral estrogen breast development. Pubic axillary hair usually sparse absent, needs androgen action. Gonadectomy needed post-puberty due to malignancy risk.
Malarianogenesis MRKH. 46XX. Absent uterus vagina. Normal ovaries, associated anomalies.
46XXX karyotype. Congenital absence of uterus and upper vagina. Ovaries are normal, so normal secondary sexual development occurs, often associated with renal and skeletal anomalies, not testicular feminization. Old term for AIS.
Okay, the postpartum period. Uterine involution. How quickly does it shrink? Back to normal size when?
Fundus descends about 1 centimeter per day. Right after delivery at umbilicus. 1 week, midway, pubic bone umbilicus. Back to non-pregnant size by about 6 weeks postpartum, not 12 days. Should feel firm, non-tender.
Subinvolution causes.
Yeah.
Retained products. Infection.
Yes, failure to involute properly. Causes: retained placental fragments, membranes, endometritis infection, fibroids interfering with contraction, full bladder getting in the way, breastfeeding, HELPS involution, oxytocin release. C-section itself doesn't prevent it.
Lochia discharge, stages, rubra serosa alba, duration.
Lochia rubra, red blood, first few days, 1 to 4. Lochia serosa, pink-brown, days 4-10 approx. Lochia alba, yellow-white, can last up to 6 weeks.
Postpartum hemorrhage, PPH, primary versus secondary. Definition.
Primary PPH, 500 milliliter blood loss, vaginal delivery, 1,000 milliliter C-section within first 24 hours. Secondary PPH, excessive bleeding from 24 hours up to 6-12 weeks postpartum.
Causes. The 4 T's. Tone is most common.
Yes. 4 T's. Tone, uterine atony, commonest cause. Trauma, lacerations, uterine rupture, tissue, retained placenta membranes. Thrombin, coagulopathy.
Risk factors for atony. Prolonged labor. Multiples. Big baby. Choreo.
Yes. Prolonged labor, oxytocin augmentation, multiple gestation, polyhydramnios, macrosomia, choriamnionitis, grand multiparity, 5 births, fibroids, general anesthesia. Premature labor is not a risk factor. History of previous PPHIS, a major risk factor.
Management. Fundal massage. Uterotonics. Find the cause.
Immediate actions. Call for help. Fundal massage. Give uterotonics. Oxytocin infusion, ergometrine methergine, IMIV, check BP, carboprothimabate, IM, careful with asthma, misoprostol, rectally orally. Secure 5E access, fluids, blood transfusion if needed. Systematically find and treat the cause. Check tone, examine for trauma, ensure no retained tissue, consider thrombin issues.
Further steps if bleeding continues. Tamponade. B-Lynch. Hysterectomy.
Yes, consider intrafauter and balloon tamponade, Bakri, surgical B-Lynch compression suture, uterine artery ligation or embolization, if available, and ultimately hysterectomy as a life-saving measure.
Example Q121. Forceps delivery bleeding, but uterus firm and below umbilicus. Cause.
If uterus is firm and well contracted, bleeding is likely due to genital tract trauma, laceration of cervix, vagina, perineum. Needs careful inspection.
Example Q291. GFP3, 2L loss, tachyhypertensive, management.
Severe PPH with shock. ABCs first. Aggressive resuscitation with fluids, blood products. Uterotonics. Simultaneously find and manage the cause, likely a stony, but check trauma tissue. 4V iron is irrelevant in acute phase.
Example Q253. Forceps, bleed, firm uterus. Cause again.
Again, suggests birth canal trauma is the likely source if the uterus is firm.
Puerperal infections postpartum. Endometritis, UTI, mastitis, wound infection. Risk factors. C-section biggest.
Yes, C-section is the single biggest risk factor. Others: prolonged rupture of membranes, prolonged labor, multiple vaginal exams, retained products, manual placental removal, internal monitoring. Prolonged pregnancy itself isn't a risk factor.
Endometritis symptoms.
Yeah.
Fever, tender uterus, phaulicia. Treat.
Yes, classic signs. Treat with broad-spectrum IV antibiotics, Visi, clindamycin plus gentamicin.
Mastitis. Breast infection. Unilateral usually. Fever, pain, redness. Organism.
Usually unilateral inflammation infection, fever, localized pain, redness, hardness, usually caused by Staphylococcus aureus.
Management. Keep breastfeeding.
Yeah.
Antibiotics.
Yes.
Crucial to continue breastfeeding or pumping from the affected breast to ensure drainage. Antibiotics effective against staph, example, flucloxacillin, dicloxacillin. Analgesia, if abscess forms, needs drainage.
Example Q692, 3WK postpartum, breast pain, fever 40C, hard red quadrant, mastitis. Treat.
Classic mastitis needs antibiotics, analgesia, and continued breastfeeding pumping.
Postpartum blues versus depression versus psychosis. Blues common, transient. Depression longer, severe. Psychosis rare, emergency.
Correct. Blues very common, mild, resolve within 2 weeks. Depression more severe, persistent, 2 weeks, impacts function, needs treatment. Psychosis is rare, severe, rapid onset, psychiatric emergency, often linked to bipolar schizophrenia history but can be de novo. Psychosis often responds well to treatment but high recurrence risk. Symptoms can be manic, depressive, mixed, not always history, mental illness, more mood than schizophrenia based.
Lactation hormones, prolactin, oxytocin.
Prolactin makes the milk. Oxytocin ejects the milk. Letdown reflex. Frequent suckling maintains prolactin supply.
COCPs interfere. Progestogen only. Okay.
Combined pills, especially higher estrogen dose, 30 milligrams, can potentially reduce milk supply. Progestogen-only methods, POPs, implant, injection, LNG, IUS, are generally considered safe and don't usually affect lactation.
Return of menstruation. Non-breastfeeding versus breastfeeding.
Non-breastfeeding women usually get period back around 6-10 weeks postpartum. Breastfeeding women experience variable delay due to lactational amenorrhea. First period usually within 10 months if not breastfeeding.
Okay, last major section. Fetal assessment and development. Embryonic period. Conception 2. Organogenesis.
Conception to end of 10 weeks LMP, which is 8 weeks post-conception. Yes, this is the critical period of organogenesis.
Fetal period. 11 weeks onwards. Growth maturation.
Yes, from 11 weeks LMP until term. Focus shifts to growth and maturation of the formed organs.
Teratogenic period. When most vulnerable. Weeks 5-10 LMP.
The classic critical period for major structural defects is roughly day 17 to day 56 post-conception, which aligns with weeks 5-10 LMP, or weeks 3 to 8 post-conception. Example Q419. Day 30-70 after LMP fits this window.
Fetal circulation. Oxygenated blood from placenta via umbilical vein.
Bypasses.
Via the single umbilical vein. Much bypasses the liver via the ductus venosus canavivis right atrium.
Then shunts across. Form an oval. To left side.
Yes, most oxygenated blood goes RA, form an ovally LA, LV aorta to brain heart.
Deoxygenated blood from upper body. SVC, OA, LE, RV, PA, then shunts via ductus arteriosus.
Correct. SVC blood goes RA, OV, pulmonary artery. Most bypasses lungs via ductus arteriosus to descending aorta.
Key points. 1 vein, 2 arteries. DA bypasses lungs. FO shunts oxygenated blood.
Exactly. 1 umbilical vein, O2 rich, 2 arteries, O2 poor. Ductus arteriosus shunts blood away from lungs into aorta. Foramen ovale shunts the most oxygenated blood from IVC to the left side, not 2 veins. Lung blood flow very low. Prostaglandins keep the ductus arteriosus open.
Amniotic fluid. Main source later in pregnancy. Fetal urine. Lung liquid. Removed how?
Main source becomes fetal urine production. Also, fetal lung liquid contribution. Removed primarily by fetal swallowing. Components added via urinary respiratory tract. Not from intramembranous flow across placenta cord. Not transmembranous from uterine circulation.
Umbilical cord structure. 2 arteries, 1 vein. Wharton's jelly.
Yes, the classic 2 arteries, 1 vein, surrounded by protective Wharton's jelly. Accordia, absent cord, is extremely rare. Velamentous insertion, vessels run in membranes before placenta, whisks vasa previa. True knot usually forms early in pregnancy, rightward coiling potentially worse than leftward.
Single umbilical artery, SUA. Increased risk of anomalies.
IUGR.
Yes. Associated with increased risk of congenital anomalies, esperenal, cardiac, GI, IUGR, and chromosomal abnormalities. It's not insignificant, occurs in 1% births, so not rare, but not 5%. Not equal diabetic, non-diabetic.
Congenital anomalies linked to fluid volume, oligo-associated with, poly-associated with.
Oligohydramnios associated with bilateral renal agenesis, PUV, sometimes polycystic kidneys, conditions reducing urine output. Polyhydramnios associated with conditions impairing swallowing, GI atresia, NTDs, some neuromuscular, or increasing fluid, hydrops, maternal DM, multiples.
Diabetes-associated anomalies. Cardiac, NTDs, caudal regression.
Yes, specifically cardiac, VSD, TGA, NTDs. Caudal regression syndrome is highly specific. Also, renal agenesis, situs inversus.
Chromosomal anomalies associated with exomphalos, duodenal atresia.
Yes, exomphalos, omphalocele, duodenal atresia, cystic hygroma, diaphragmatic hernia often associated with aneuploidy. Gastrocesis usually isolated.
Teratogens, valproate, rubella.
Phenytoins. Valproate NTDs, rubella, first tria, cardiac PDAPS, deafness, cataracts, microcephaly, IUGR, not intracranial calcification, that's toxo-CMV, fetal hydantoin syndrome, phenytoin, growth deficiency, developmental delay, dysmorphic face, hypertelorism, broad nasal bridge, clefts, hypoplastic nails, phalanges, not macrocephaly.
Sexual differentiation.
Yeah.
Genetic duodenal xanthomate phenotypic testes make. MIF regresses.
Correct sequence. XY testes. Testes make testosterone, develops Wolffian ducts alveolus, epididymis seminal vesicles, and MIFMH causes Müllerian duct regression.
Neonothic testes means default female. Wolffian regress, Müllerian develop.
Yes. XX or XY without test androgen action. Wolffian ducts regress, Müllerian ducts persist, fallopian tubes, uterus, upper vagina.
Male external genitalia need DHT. Female external default.
Yes. Testosterone converted to DHT needed for penis scrotum development. Female external genitalia, clitoris, labia minor or majora, form from genital tubercle fold swellings and absence of androgens. Not true. Removing gonads leads to chromosome-based development, defaults female. XX doesn't make gonads ovaries, it's lack of SRY. External genitalia from cloacal structures, not just cloaca. Vagina forms from Müllerian ducts, upper 23, plus urogenital sinus, lower 13, canalizes by 20 weeks. Swellings, labia majora, folds, labia minor, tubercle clitoris.
Oh, you're nearly there. Operative gynecology anatomy wrap-up. Hysterectomy types, total versus radical.
Total hysterectomy removes uterus and cervix, not tubes ovaries unless specified. TAH-BSO. Radical hysterectomy, Bertheims for early cervical endochi, removes uterus, cervix, upper vagina, parametria, uterosacrals plus pelvic nodes. Not ovaries, tubes unless specified, not omentum.
Complications of hysterectomy. Bleeding, infection, injury, VTE.
Hemorrhage, infection, wound, UTI, pelvic, injury to bladder or bowel, VTE, nerve injury. Commonest overall is infection, wound, UTI. Typical timings, wound D5, disruption D48, UTI D13, DVTP, D712. UTI not usually within 24 hours.
Hysteroscopy complications. Perforation, fluid overload.
Uterine perforation, fluid overload from distension media. Pulmonary edema, hemorrhage, infection, air gas embolism, not cervical incompetence.
Laparoscopy complications. Bowel bladder vessel injury.
Hernia.
Yes, injury to surrounding structures, hemorrhage, infection, gas embolism, rare. Port site hernia later.
DNC complications, perforation. Asherman's.
Perforation, hemorrhage, infection, Asherman's syndrome, intrauterine adhesions. Minimal RH risk unless significant bleed. Doesn't directly cause cervical incompetence unless overdilated. Pelvic anatomy, uterine support levels.
Oh.
Level 1 apical. Cardinal uterosacral is most important.
Yes, level 1, cardinal uterosacral ligaments for apical support is key against prolapse. Level 2, mid-vagina, perivaginal fascia. Level 3, distal, perineal body muscles.
Pelvic inlet boundaries. Promontory arcuate line. True pelvis below.
Inlet bounded by sacral promontory ala, arcuate line, pectineal line, pubic crest symphysis. True pelvis is below this brim.
Mid-cavity. Plane of least dimensions. Ischial spines define narrowest diameter.
Yes, bounded by lower symphysis, ischial spine, sacral tips S4-5.
Yeah.
Transverse interspinous diameter is narrowest, 10 centimeters, and not bounded posteriorly L4-S1, not laterally, just pubic bone.
Pelvic outlet boundaries. Pubic arch. Ischial tuberosities.
Pubic arch, ischial tuberosities, sacrotuberous ligaments, cossack X.
Pelvic diameters. True conjugate. Obstetric diagonal. Shortest AP inlet.
True conjugate, 11 centimeters, prom top symph. Obstetric conjugate, 10.5 centimeters, prom mid-post symph, shortest AP inlet. Diagonal conjugate, 12.5 centimeters, prom bottom, symph clinical measurement. Obstetric is shortest.
Female versus male pelvis. Female wider, shallower, wider arch.
Female, wider, shallower, larger, rounder inlet outlet, wider pubic arch, 90 degrees, cylindrical cavity. Male, narrower, deeper, heart-shaped inlet, narrow arch, 90 degrees, cone-shaped cavity. Not male arch, less acute. Not male AP outlet, larger. Not male transverse, smaller.
Ureter course. Water under the bridge. Near cervix.
Yes, ureter passes under the uterine artery near the cervix. Right ureter also near IP ligament, appendix base, crosses external iliac bifurcation.
Vulva blood supply mainly. Ovarian vein drainage.
Vulva mainly from pudendal artery, ovarian veins, left drains to left renal vein, right drains directly to IVC.
The ovary relations. Ovarian fossa. Ureter posterior.
In ovarian fossa, ureter is posterior, external iliac vessels posterolateral, obturator nerve vessels lateral, broad ligament anteromedial, not tube anterior, not broad ligament posterior, not external iliac posterior.
Pudendal nerve. Sensory perineum. Motor sphincters.
Sensory to perineum, motor to external anal sphincter, external urethral sphincter, bulbospongiosis, ischiocavernosus, not sensory to uterus, not motor to levator, anteobturator internocity bladder.
Okay, final topic area. Menstrual cycle and disorders. Normal cycle length. Phases.
Average 28 days, follicular phase, variable length, ovulation, day 14, luteal phase, fixed 14 days.
Ovulation timing relative to LH surge. BBT change. Mucus change.
Ovulation 24-36 H's after LH surge starts, 10-12 H's after peak. Basal body temp rises after ovulation, progesterone effect. Cervical mucus becomes thin, watery, stretchy, spin bark height, pre-ovulation estrogen, then thick, scanty post-ovulation progesterone.
Endometrial phases. Proliferative.
Secretory.
Proliferative phase driven by estrogen.
Proliferative phase.
Secretory phase driven by progesterone after ovulation. Luteal phase.
Normal menstrual blood loss amount.
Average 30-40 millimeters. Upper limit of normal often cited as 80 milliliter. Q405 suggests 25-50 milliliters.
Abnormal uterine bleeding, AUB.
Menorrhagia.
Heavy regular.
Yes, heavy 80 milliliters for 7 days, but regular cycles. Causes: fibroids, adenomyosis, polyps, DUB, hypothyroidism, coagulopathy. That covers the main topics from the dossier, I believe. Wow. That truly was an exhaustive deep dive into, well, everything OBGYN, wasn't it? Meticulously hitting every point for that final exam revision.
We definitely covered a vast amount of ground there, pulling straight from the OBGYN final exam dossier. The aim was really to arm you, the learner, with a solid, comprehensive foundation.
Think of this as your intensive, fully curated guide. We've highlighted all those key concepts, pointed out potential tricky areas, the pitfalls, those crucial differences between conditions.
Exactly. We've unpacked definitions, explored all those predisposing factors, really dug into the management strategies, and hopefully clarified some of the nuances between normal and abnormal processes right across obstetrics and gynecology.
And remember, this deep dive, while exhaustive, is really designed to be that springboard for your own deeper exploration. If any specific area felt complex or maybe sparked more questions.
Definitely go back to your source materials, your textbooks, your notes. Dive deeper. Those aha moments often come with that continued engagement, really wanting to grasp the why behind things.
As you finalize your preparation, maybe hold on to this thought. The incredible interconnectedness of everything we discussed, it's key, isn't it?
Absolutely. How pregnancy physiology impacts complications, how hormones link to gyna conditions, how anatomy underpins safe surgery. It's all interwoven.
Well, thank you for joining us on this incredibly comprehensive journey. We genuinely trust this deep dive has given you that robust framework and all the critical info for your OBGYN final exam.
Go forth and master this material. Good luck.